I welcome you all to the daily rounds in anesthesia. I am Dr. Sunandha Gupta, Professor and Head of Anesthesia in Geetanjali Medical College and Hospital, Udaipur. It's a pleasure to meet you all here. And I am also the Founder President of the Association of Obstetric Anesthesia in India. Now, as you all know, failed spinal for cesarean section is a cause for concern to all of us. Spinal anesthesia is the most common technique of anesthesia that we all use both for elective as well as emergency cesarean sections. Now, the percentage use of general anesthesia is considered a marker for the quality of obstetric anesthesia in every unit. And the decline of the use of general anesthesia for cesarean section has resulted in two major indications for using general anesthesia, and that is the urgency of cesarean section and the failure of regional anesthesia. Now, choosing alternative techniques means that you expose the parturient to a less safe, less favorable, and maybe a detrimental technique which could be detrimental both for the mother and the fetus. And so we should consider a failed spinal anesthesia as an avoidable complication. We should not ignore it as an unfortunate incidence. I have no disclosures relating to this presentation and will quickly go through the overview of what I'm going to discuss. I'll be early on discussing what are the new guidelines for grading emergency cesarean section, and then we'll go on to what exactly do we mean by decision to delivery intervals, what do you mean by failed spinal, what is the incidence, the best practice, what are the management strategies, what are the algorithms which have come into play, and then we go on to an important topic, that is the medico-legal implications, and then I'll sign off with a take-home message. Now, the first recorded failure came on 24th August 1898 when two friends, August Bayer and Hilbrand, both injected cocaine into the intrathecal space of each other. August Bayer was successful, so Hilbrand did not feel the pain of a hammer tongue on the shin or pressure on the testicles. But when August Bayer was injected with cocaine, the injectate leaked out from the hub of the needle. And so we had the first failed spinal which was recorded. Now, as you know, that a classification relating to the degree of urgency to the presence or absence of maternal and fetal compromise was introduced early on in 2010. But before that, in 2000, the classification of emergency cesarean section was graded according to a discrete category 1 to 4 category. But this was changed to a color-coded scale which told us about the maternal as well as the fetal compromise. In 2011, NICE came out with the guidelines for overall performance of an obstetric unit, and what they said was category 1 cesarean section should be completed within 30 minutes, but a category 2 cesarean could go on for another 15 minutes. That means around 75 minutes they could take. So why standard uncomplicated spinal anesthetics fail to produce an adequate sensory block? Now, in the literature, failure rates have been reported up to 17%, but mostly it is somewhere around 6 to 7% in most of the centers. And if we are very meticulous about the technique, then we can reduce this complication rate to less than 1%. So what are the 5 phases of spinal anesthesia where we can make mistakes? The first is when you give your lumbar puncture, when you inject the solution, the dose and the spread in the cerebrospinal fluid, and the drug action on the target sites, and finally how well you manage the patient during the post-injection phase. So first of all, we'll talk about lumbar puncture. We usually use the pencil point needles because it is considered to be the best so that no post-dural puncture headache occurs. Now, if you look at this diagram on the left hand side, you'll appreciate that when the pencil point needle is kept, the bevel is kept within the subarachnoid space, you'll find that the injectate is deposited in the subarachnoid space. But if the bevel straddles the dura, you'll find that half the injectate goes into the epidural space. And if you look at the diagram on the right hand side, there's another complication that can occur with the pencil point needle. The bevel, when you introduce the pencil point needle, you'll find that a flap of the dura and the arachnoid is formed, so that when you aspirate the CSF, you're successful, but when you try to inject it, you'll find that the flap of the dura blocks the upper end of the bevel and most of the drug is injected into the epidural space. Or it can happen that the subarachnoid and the dura split up and you tend to inject the injectate into the subdural space. So this is one complication we all need to be very cautious about when we use pencil point needles. Another important complication, and we get a lot of relief when we say that the bupivacaine was bad and we blame it for the failed spinal. But according to AnesthesiaRounds and most of the companies which prepare our local anesthetics solutions, that is the amide solutions, they say that it is very heat stable as compared to the esters we used to use beforehand. At 120 degrees centigrade for 15 minutes, there is no degradation. And if you look at the graph here, long-term storage at more than 38 degrees centigrade, only a minimal amount of degradation occurs. So it is quite an insignificant degradation. Now what about the dose of the drug? Bupivacaine, if you add adjuvants like opioids, the ED50 is around 7.5 milligram, but for surgical access you require about 11 milligram for ED90. Now you look at this limbo dancer, she keeps going down and down and down, but she is very careful about not disrupting this bar. So is that anesthesiologists can keep on going down, decreasing the doses, but be careful that you do not compromise the safety of the patient. Now there are some technical considerations which are anatomical in nature, which could cause maldistribution and cause a failed spinal. For example, this fibrous septa in the subarachnoid space can lead to maldistribution. Again, a Tarlov cyst, which you can see here, is filled up with cerebrospinal fluid, and when you aspirate during a spinal, you find CSF comes out, but when you inject your solution, you find that this does not have a communication with the intrathecal space. So you have a failed spinal on your hands. Again, the variability in the anatomy of the subarachnoid space, a large intrathecal volume can lead to maldistribution as seen with the Marfan syndrome. This is an interesting article which came just recently in April. This is on 5th April that it was released, Anesthesia and Analgesia. They looked at more than 3,000 spinals. This comes from an Italian group, and they found that the failure rate was close to 6.2%. And 72% of them were presumed to be total failure. But then was it complete failure? They found that in 44%, that is 32 patients, they found a restricted sacral block. So you need to be very careful to decide before that it is a complete failure. Now the dose of local anesthetic decides on the speed of onset, the quality of the block and the duration of the block. While the density or baricity of the solution, the volume of the CSF and the position of the patient, all these decide the level of or height of the sensory block. If you add adjuvants like opioids or clonidine, it tends to accelerate the onset, prolongs the block, and also accentuates the motor block. The fourth point, important point that we come on, is the drug action on the target sites. Now the loss of potency, as we talked about early on, and the concentration errors could be a cause for maldistribution. Chemical incompatibility when you use adjuvants or when you mix two different anesthetic agents, that could be a cause. The alkaline pH of the CSF. Now what happens, the This causes a decrease in the unionized fraction so that the injected does not penetrate into the subarachnoid space and have an action on the spinal nerve roots and the spinal cord. Bloody taps again can lead to absorption into the bloodstream, and another cause for concern is mutation of the sodium channel, which renders the local anesthetic ineffective. There is a lot of literature coming up recently about mutation of these sodium channels. Now in the post-injection phase, if you're very meticulous about this technique, you would like to give a slight head down position with a left lateral tilt. And remember, you need to test your block always from below upwards so that the patient is more comfortable. She knows that some amount of block is there and she will not go into a panic situation. So check the motor block first, and then a T10 level is required for a skin incision. Maybe when you have a successful spinal on your hands, you will find that at T10, when the surgeon gives an incision, the patient will not complain, but the moment the viscera is handled, you will find that the patient screams out with pain, and this is because your block has not reached up to T4. So be cautious, and intra-abdominal stimuli through unblocked parasympathetic and phrenic nerve fibers would precipitate a dull visceral type of pain and cramping during surgery. And remember, this is an important cause of medico-legal litigations. The Royal College of Surgeons of Anesthesiologists came up with the best practice regarding the conversion rate from neuraxial anesthesia to general anesthesia, and they said that if it's a elective caesarean section, then only less than 1% should be the conversion rate, while if it is an emergency caesarean section, it should be less than 3%. And so this Royal College of Anesthesiologists, they came up with the guidelines for every obstetric unit, and they say that if it's an emergency caesarean section, remember your conversion rate to reach general anesthesia should be more than, the conversion rate should be less than 15%, while all caesarean sections should be conducted under regional anesthesia in more than 50% of the cases. But if it's an elective caesarean section, all regional anesthesia should be more than 95% and your conversion rate should be less than 1%. Remember, if it's an emergency caesarean section, up to 20% pain is acceptable, but with elective caesars, it should be less than 5%. So some of the common reasons for failure which has come up in this study by the Royal College in 2012, they say that lack of a dedicated obstetric anesthesiologist and lack of a good assistant to give you a position, misunderstanding or misclassifying the urgency of the caesarean section, and also inappropriate assessment or recording of the block could be important causes for failure. So the most important causes factors which could predict a successful failure. If it's a lean and thin patient, you can see the anatomical structures. If the assistant gives you a proper patient positioning, and the level of anesthetic experience could always have you with a good successful block in the first attempt. So then what is the next best option when you have a failure on your hands? Every unit should have its own failed spinal drill. Now this depends on the urgency of the caesarean section as well as the time at which it becomes apparent. Whether it's after skin incision or before skin incision, and whether you have less than 30 minutes or more than 30 minutes on your hand. But remember that before designating it as a failed spinal, you should wait for 20 minutes to see whether this effect has been possible or not. So if it's after skin incision, you have less than 30 minutes on your hand, you need to give general anesthesia for an emergency caesar. But if you have more than 30 minutes on your hand, then try to revive the block or salvage it with giving oxygen with nitrous oxide, ketamine, doses I'll discuss in the subsequent slide, fentanyl, doses of 10 to 20 mics, aliquots, wound infiltration by the surgeon, counseling during the failure by the anesthesiologist, a Valsalva maneuver, asking the patient to cough, that would increase the pressures in the extradural space and help in extending the block. Now, if it is before skin incision, you have less than 30 minutes on your hand, repeat the block or salvage the block and prepare for general anesthesia. But if you have more than 30 minutes on your hand, then repeat the block, and an ideal situation would be if you give a combined spinal epidural. So at this juncture, you could change the position by flexing the hip and knees, give a head down tilt, give a full lateral position to the patient, maintain it for 2 minutes, and then a lateral position on the other side, and you give a head down tilt with it. If you are repeating the spinal, remember, if you have given it in the lateral position, change over to a sitting position, change the concentration of the drug, change the interspace where you gave it, change from hyperbaric to isobaric, and maybe a different drug that could help you out with a failed spine. According to Edenbrook's acute pain service guideline, the rescue ketamine is the best option. Of course, if it's when the patient is not full stomach, you give 1 milligram of midazolam IV ketamine, 0.5 milligram per kg loading dose, and then give during visceral manipulation or hemostatic 4 microgram per kg per minute. Once the retractors are being removed, you can reduce the dose to 2.5 mics per kg per minute and discontinue it on application of the dressing. Now, what are the concerns on repeating a failed neuraxial block? Should it be the full dose that should be given? Now, according to the dress nurse guidelines, if you find the CSF at the hub of the needle, or you find that there is some amount of sacral block that is present, you should always reduce the doses by 25 to 30%. Give 9 milligram if the block is around T10. Now, multiple punctures of the dura has its own implications. Remember, some amount of local anesthetic may be present around the spinal cord, and this could lead to risk of nerve damage as well as cardiac lesions. And apart from this, it could lead to postdural puncture headache, vascular injections, and delayed subdural. So you need to be very cautious when you are repeating the neuraxial block. An ideal situation would be where you could give a combined spinal epidural and extend the block further. So guidelines to reduce the neurotoxicity following repeat CS: always look out, attempt CSF aspiration before and after the block. Evaluate the sacral dermatomes. Very important, either you put the patient in a lithotomy position or turn the patient on the lateral side to examine the dermatomes. Do not exceed the recommended safe doses. Modify the technique, as I said, if it's a lateral position, change over to a sitting position and confirm the status of the block, whether it's partial or a total fail. To avoid or reduce the incidence of failure, this group from Singapore talks about giving opioids or clonidine as an adjuvant, and techniques like combined spinal epidural would reduce the incidence of failure. Always check the height of the block with loss of touch to T4. Now, a cause for concern for all of us as anesthesiologists is the medicolegal implications. Now, extreme pain during cesarean section, as well as our reluctance to convert it into general anesthesia or any other form of anesthesia, could be a cause for medicolegal implication, as well as the more serious complications like severe hypotension, nerve injury, or a negative outcome for both the mother and the child could be a cause for litigation. Now, always remember, whatever you do, you have to have proper documentation. Otherwise, poor documentation means poor defense. So when you advise your parturients during the pre-anesthetic evaluation, always then tell them that it's going to be a pain-free anesthesia, but not sensation-free. the pushing that the assistant does during cesarean section and delivery of the baby could be a cause for discomfort in the upper abdomen. Now explain the technique, explain how you are going to test the block, how you are going to manage any pain that appears, and how you are going to convert it into general anesthesia. Also advise the partner about this procedure that you might undertake during anesthetic procedure. Now give your block adequate time before you decide that it's going to be a failed block, and check the sacral dermatomes for restricted block. Remember, this is very important when you try to give a repeat block and you do not overstep the doses that are recommended. So key points to safe practice: informed consent. When you take a consent, please take consent for both regional anesthesia as well as general anesthesia. Meticulous documentation. If you are given ketamine, please mention the doses that have been given and the effect that has taken place. And also, if the patient has refused general anesthesia, please jot it down. All obstetric units should have their own failed spinal anesthesia drill. And in case of failure, remember, good communication, giving a sympathetic ear to her complaints during cesarean section will go a long way to avoid litigation. Thank you.